two more questions. Does this change the calculus in how we approach patients with surgery for stage 3A? I mean, I think I've asked you this question before. You know, a patient who's surgically resectable should potentially, you know, have surgery at some point along the treatment continuum if they're a stage 3A and the surgeon deems to be surgically resectable. Does this improved outcome we see with Durva change the way we think about surgery in stage 3?
What it does for me is make the possibility of improving outcomes even for patients with surgically resectable disease with immune checkpoint inhibition. But that is a question for a clinical trial. Yeah. I think to move this paradigm into the resectable setting at this point would be premature. What we have seen already are some promising data coming out that in patients with resectable lung cancer, giving immunotherapy as preoperative treatment has some very favorable results. So there are already randomized trials looking at how does this fit in the surgically resectable population. I don't think, even though there is a little bit of overlap, the surgically unresectable stage 3s and the resectable stage 3s are distinctly biologically different groups of patients. And we need to treat them as such.
It's interesting here because we have some differences in the way we qualify resectable stage 3 in Europe and in US. I think we are more liberal in the way we still consider a patient operable or resectable in Europe. You know, we go for stage 3A multi-station N2. We go sometimes for very bulky disease, even at the limit of a T4, invading some noble organs. So our surgeons are quite strong, right, in Europe. So it means that we had this tendency or this trend to propose surgery first and by definition radiation as really second choice. I think this trial has changed a little bit the game because all these marginally resectable patients where we had 10 or 15 or 20 minutes discussion at the multidisciplinary tumor board. Now you can maybe cut the discussion telling we have a good treatment to give to this patient, which is probably simple and probably more, I would say, rational in terms of age, PS, and tumor extent. So I think it really offers us a very promising new strategy to maybe spare some patients from very invasive, very large surgery. And that's something for Europe, which is probably a positive move.
I think that's right. You know, the question about borderline resectability has been one that we debate a lot of the time. And in fact, you know, with multi-zone N2 disease, there are a lot of surgeons in the UK and many parts of Europe that wouldn't even consider resecting that patient, to my mind, appropriately. And I think this has entirely shifted the balance of the sands because we now have a treatment which has been proven to improve survival compared to discussing with colleagues whether surgery is bringing any benefit or not. So I think to my mind we're going to be appropriately seeing less surgery in these borderline cases and implementing far more radiation. But one of the areas that I wanted to mention, Ben, is there's a lot of chemoradiation that occurs in the sequential setting in many parts of Europe, certainly in the UK.
Yeah. Still the standard for stage 3 for the most part in the UK?
You know, I think there's a lot of sequential chemoradiation, mainly because around the previous concern about the additional toxicities for marginal benefit with concurrent versus sequential chemoradiation. But now we have a data set which mandates concurrent chemoradiation. So we need to ensure that all our patients that are suitable for concurrent chemoradiation are getting it. Yeah.
One more question regarding this data set that will dovetail into another section we'll talk about soon. The EGFR subset in this trial, they're the one group that really didn't benefit, and I think we have to be mindful of subset analysis and hazard ratios from forest plots. This is a question that comes up. You know, a patient who's EGFR positive, that didn't seem to be a group in the trial that garnered a statistically significant benefit. We know that EGFR mutations may not do well with at least single agent checkpoint blockade. Yeah. What are people's thoughts about using durvalumab in a stage 3 patient who's EGFR positive who completes concurrent chemoradiation? Is it, I don't know if there's a right or wrong, but this is why we have these perspectives here. So
the first answer is to say in most of these patients we simply don't know because usually it's not routinely done to test for EGFR in locally advanced disease or in early disease. But would you have to know about it? I think there are very few data telling you that this strategy, which basically is probably creating some immunogenicity. We remember the data of IMpower 150s. Well, you combine with bevacizumab, you observe still a benefit in EGFR mutants, it might be the case for this trial. And like Ham was telling before, this kind of question should not be answered by our intuition or our thought, but it requires a trial if you want to decline or to kind of prevent a patient from receiving this drug prolonging strategy if he's EGFR mutated. So I wouldn't decline this treatment to any patient without a dedicated trial, because probably maybe the combination with chemo and radiation creates an environment where some immunogenicity is gained. So this is really something that I would be very careful about. Remember, in this trial, this will be a huge debate in Europe. Almost half of the patient has an unknown PD-L1 status, or 40-something. So it means that many of them have no EGFR. So this is not a setting where biomarkers is the game player. The game player is the locally advanced disease.
In a nice way. I mean, and it's for all patients, at least seems everyone benefit, at least in PFS. I agree. I've been more comfortable. I think we need trials. I think that, it's tough to draw conclusions from subset analysis in EGFR mutant in that trial. So I've been inclined to give it to them in the absence of any other outside of a clinical trial.
Well, I think you're right there. I think you have to have a good reason not to give it to them, and the data doesn't really support omitting them on the quality of the data that we have. I mean, at the end of the day, it's a subset, unplanned analysis of a relatively small number of patients with a wide confidence interval, with the point estimate showing some benefit. So there isn't enough data, I think, to withhold that treatment from that group.
Yeah. All very good points.